My apologies for not being there in person. And instead of playing a role of host, I'm playing as a guest. I really feel a little bad. Okay. So I had commitments to fulfill here in IGCTO. But my special thanks to West Bengal CSI, Prakash Da and Dr. Anmol. And we witnessed brilliant lectures, Dr. Anup and Dr. Anmol. So my job is to discuss lifetime management of severe aortic stenosis. And not long back, 6, 7 years back, when a tower was done, the operator used to feel this patient should be through the procedure and he should survive the procedure. But now, at this moment, at this juncture of time, once we do a tower, we look at how the patient is going to behave after 5 years, 7 years, or 10 years down the line. And that is why a lot of talk about lifetime management. But at the outset, I must tell, all the literature which is there from Western world may not be applicable to our Indian scenario, because our life expectancy is less and we have more of bicuspid aortic valves. We just heard Dr. Anmol about the challenges we face among bicuspid aortic valves. 30% of our population has, the tower going population has bicuspid, anatomy. And they are really, the outcome is not the same as what we see in the literature. So to begin with, these are the recommendations. A patient who is less than 65 years and a life expectancy of more than 20 years, a SAVR is recommended, and that is there is no dispute there. But 65 to 80 years, and if the patient has a favorable anatomy for transfemoral TAVI, and then we strike a balance, and it's a shared decision making between the patient relatives and the patient's life expectancy and valve durability. We decide which way the patient should go. More than 80 years and the life expectancy is less than 10 years, and there is no anatomical contraindication to transfemoral TAVI, we go for a TAVR as a preferred option than surgical aortic valve. So what we see here in managing the patient and looking at the lifetime management of the patient, the best would be putting a one valve, be it a surgical, be it a transcatheter aortic valve, and it stays for the patient for life. But it doesn't happen. We have a kind of 10 to 15 years durability of valves, and that is why 2-3 things especially pop up when we decide. One is life expectancy, how much the patient is about to live, and second is valve durability. And then there are some nuances like the small annulus, the bicuspid anatomy, and then coronary access, and then how the pacemaker patient is going to behave after TAVR, or acquired LBV patient, how they are going to behave. So we'll talk to about them separately. So tissue valves are basically outsmarting, and this is getting more and more popular nowadays. And even younger patients, they are opting for tissue valves because they are free from comedoine, stroke, and bleeding risk is less. And tissue valve, this is a surgical tissue valve data where they have shown around 75 to 80% valve durability at 10 years. Hopefully the same goes through and apply to our experience of transcatheter aortic valves as well. And I will discuss about these data. And the native valve and the bioprosthetic valves which is deployed, they are different because a native valve can self-repair itself. And a bioprosthetic valve which is deployed can't self-repair, and it is a treated valve, so the degeneration is faster. And that too, some of the challenges which are unique to TAVR is the valve's leaflets in transcatheter aortic valve is thinner. So it's 0.25 millimeter as compared to 0.4 millimeter. So a thinner valve, there is apprehension that how it is going to behave with such a shear stress. And second, the valve is crimped on a platform, and sometimes TAVI frames are oversized to minimize the risk of paravalvular risk, regurgitation. So these are challenges and apprehensions which were there, and that could lead to valve dysfunction, structural valve deterioration. But it's not all structural valve dysfunction is structural valve deterioration. There's a good number of PPM patients, patient processes mismatch, and sometimes thrombosis, endocarditis, they also play a role. So here we have to decide which valve needs to be given so that the patient's patient prosthesis mismatch is less and patient's longevity is higher. So WARC 3 has given a defined criteria for structural valve, deterioration. So these are some data about how 5 years, 7 years, different valves behave, but the most prominent and only randomized controlled trial till now in valve durability assessment is a Notion trial where self-expanding platform core valve was compared with surgical aortic valve, and it was really, really promising. At 5 years, all-cause mortality, stroke or MI was similar, and even less than 4% STS risk. Again, Tower and Sauer, the 5-year mortality, stroke, and MI were similar. So in high risk, intermediate, low risk population, these all they have the same kind of trend. And this is the aortic valve performance. The valve, the aortic transcatheter aortic valve performed better. There was a high and more effective orifice area, and mean gradients were less, and that was even up to 8 years. So transcatheter valves, TAVI, outperformed surgical aortic valve in Notion trial at 8 years, and that is where we are, banking on. And we believe that if not better, at least they will behave like a surgical bioprosthetic valve. And these are various trials which says the similar, story. Besides this valve durability, we had the apprehension, and now we are getting this apprehension mitigated with all these evidences. But there are many factors which needs to be taken care of, like how about the coronary access? A patient who is 66 years falling, with a intermediate or high risk for surgical aortic valve and low risk for transcatheter, you definitely go for transcatheter aortic valve. But what happens after 6 years if the patient has acute coronary syndrome? So these are data on coronary access following TAVI. So no way it is going to match the surgical aortic valve, and then we are going for a TAVI, coronary engagement and coronary procedures. These are something like normal patients we are going ahead. But in TAVI patient, this is, even though we have come a long way, newer platforms are there, but still the risk is there. So you see, even though diagnostic angiography is usually successful, unselective coronary engagement is more common with long stent valve frames, and even with short valve frames, sometimes it's a challenge. And we have seen the re-access study where self-expanding platforms behaved very difficult in coronary access. And here the commissural alignment, which we are looking at, that could reduce the risk, and the coronary engagement and coronary intervention, we feel that it should be a kind of a normal kind of work, but it's not like that. The main goal of this entire commissural alignment is not a perfect commissural alignment, but to avoid commissural misalignment. So we are never perfect with this, although we try to be on a safer side. And with this coronary access, we have to understand that if we deploy valves early, chances of coronary involvement can be there, and how to deal with that, we have to choose the valve platforms accordingly. Coming to new bundle branch blocks and pacemaker implantation, we are aware that these patients, severe aortic stenosis patients, many of these patients have got afterload mismatch. And many times we see on table, once we put a transcatheter valve, the heart function of the patient recovers. And many patients, there is a reverse remodeling happens in 3-4 months time, the heart function gains up. So 30% DF goes to 60%, sometimes instantly on lab, sometimes in 3 to 6 months. And this reverse remodeling is severely affected, especially midterm remodeling. Reverse remodeling is severely affected if there is a new bundle branch block or a pacemaker is implanted in these patients. And that is why 1 year all-cause mortality, heart failure hospitalization is high in new bundle branch block patients. And obviously these patients have a high permanent pacemaker implantation. So we are giving a problem to a patient after removing a previous problem of that patient. So that is something which we need to see and consider when we are choosing a device, lifetime device for a patient. And that is where we are doing, left CSP in all our transcatheter aortic valve patients. We have done till now 4 pacemakers in our post-TAVI patients, and last 2 were CSP, and this kind of ECG we are giving. Probably they will not lead to heart dysfunction long term, and also should not be interfering with the reverse remodeling process. And the last word is small annulus. Small annulus is one area where a lot of long-term kind of resurgery or re-intervention we expect, and that is one place also where self-expanding supraannular implantation can be a better choice. Among that, we have got multiple options now, not one, and we have to choose as and balance the risk of giving a higher effective orifice area. Also look at the coronary access and pacemaker implantation. So with these three, we decide and choose our valve make. So with this all developments, there is also a development on surgical bioprosthetic front coming with Resilia bioprosthetic tissue, where the calcification is very less, and they expect a mean durability of 20 years. And probably with this all developments, this field is really getting a lot of crazy excitements. And hopefully the dry tissue technology, the development in improvement in tower valve leaflets technology, it's going to be a very, very exciting, interesting area in next 10 years. So summarizing, we expect 10 years for TAVI. Surgical aortic valve after TAVR is not an easy job. So we should not feel that once we have done TAVR, explantation and new surgical valve can be implanted after 5, 6, 7, 8 years. This is a very difficult job. In all surgical registry, it is being shown. Valve in valve is a good option, but we have to plan at least 20 years for a patient. So we have to choose the device well, considering the patient profile, the anatomy of the aortic valve, and the risk assessment. Thank you so much for the patient.